All right, so welcome to DMS 210. This is a scanning applications course. This course was designed to integrate previous learned didactic knowledge and laboratory skills to strengthen sonographic scanning technique. Applications of these skills are also emphasized and reviewed, using your textbooks. So this course, there are going to be 4 competency exams as well as 4 tests. Again, these tests are going to be take-home tests. I have actually posted the first one already on D2L. So when you guys come in this afternoon, I'll give you all a Scantron that you can, fill out. There is one last page of that exam, the answer sheet for like the matching that you'll have to print out and just submit with your Scantron. The reason I'm doing take-home tests is because I really want you guys to just, not focus on like just trying to study, like what should I study? Should I study PowerPoint? Should I study this? Should I study that? So I made the test, difficult where you actually had to like go through the PowerPoints, look through the tests, find the answers. I feel like you're going to learn more by actually having to look up the answers and find the answers on your own. So I'll give you, you get a decent amount of time to complete the tests. And then the second component of this class is going to be our lab competencies. So I really want you guys by the end of this summer being able to do a carotid exam, no problem. Lower extremity DVT study, no problem. For newer accreditation standards, I have to teach you guys the lower extremity insufficiency exam, so the venous reflux exams. And I want you guys to be able to go through a complete abdomen as well. So with the competencies, I'm going to show you when you come in how to be able to save them to the machines and then be able to continue them at your own leisure. So, if you come in, you can do a certain segment of like, your abdominal exam, like do liver, gallbladder one day, save those images, then go back in and then restart the exam and, continue to do kidneys another day and then follow it up, do spleen and bladder. So I also feel like this course is also, I want to prepare you for being able to, write your reports, because that was another feedback that I got from a lot of the second year students and from the technologists that I would be assessing them. Like, the students are great, they can scan, but when it comes to writing up a report, they have no clue. They don't know what to say or how to, interpret what they're seeing. So I was going to go through, each week and review how to formulate these reports. Like, what's the verbiage that we use? Like, what are we reporting? What's the history that we get? So what does a preliminary report look like for each thing? As well as I'm going to spend, a class, reviewing the exams, making sure when the test is due. So it'll be due the day before we review it. So I'll have, you'll have your test submitted and then we'll go through it, all the correct answers, make sure that everyone's on the same page. We understand why the answers are, they are. I feel that's just going to be a better learning situation for us all. So we're going to do, so the first comp is going to be your karate comp. So then I posted what I feel is, would be a full, complete, thorough abdominal protocol. So I've basically like hit on everything that you'll be able to, or should be able to image by the end of the summer. So I want you guys, hitting your fall, summer, fall clinical rotations, confident in being able to, obtain all these images. So pancreas, your great vessels, being able to measure the aorta, your liver images. So we have left lobe, right lobe, hepatic vessels, portal vein. I don't know if they ever showed you how to use the high frequency transducer to demonstrate liver nodularity, but a lot of sites now are requesting you getting at least 2 images of the liver showing the capsule demonstrating or assessing for nodularity. Gallbladder, common bile duct, kidney images, spleen images, as well as bladder and demonstrating the urine jets. And then also 2 images of the pleural space or non-cardiac chest. So So that's assessing for pleural effusion. So on here, I posted, also the competencies for the carotid and lower extremity duplex, as well as the insufficiency duplex. So again, so I set due dates, that are far in advance, so you can come in, work on them. You guys are fortunate enough to have Mondays, free to have the lab for yourselves, which is kind of nice. But I think this is going to work well. The way the class had been formulated, I wasn't too crazy about it. It was a lot of testing and going over PowerPoints again that you've all already seen. So I've posted to D2L like all the PowerPoints, the old PowerPoints that you had from your first vascular class, second vascular class. I'm going to be, when we get a little further on, I'm in the process of getting all the PowerPoints for the abdominal lectures that you've had as well. So that's all going to be posted for you on D2L to use as reference sources. So you have your textbooks, you have your PowerPoints, so you can go back, reference all these things to try and find the answers, for the quizzes. Any questions about that at all? So I just have to finish up the transcranial Doppler that we didn't get to finish from last semester. And then next week we'll start in onto our formulating our clinical reports. So in the fall, we're actually all gonna get a rotation doing transcranial Dopplers. So Mary Jo over in the vascular lab is going to be teaching you this, and you're actually going to be able to perform them on each other. So with transcranial Dopplers, we have an index that's called the hemispheric index. This is the measure of the middle cerebral artery velocity divided by the internal carotid artery velocity. So this is similar to that carotid ratio that we have when we're doing the extracranial carotid arteries, where we have our distal ECA and our proximal ICA. So we create this ratio to show degree of increase in velocity, like how fast is that velocity increasing? And the reason we do this ratio for the transcranial Doppler is to distinguish vasospasms from states of systemic hyperemia, meaning states where we have increased blood flow, like global increased blood flow getting to the brain, as opposed to just a focal area vasospasm. So with this ratio, we're able to determine if there's actually a vasospasm present, or if it's just in general, the blood velocities are elevated, if there's increased blood flow to the brain. So in cases with systemic hyperdynamic states, both the MCA and the ICA will increase the velocities. So the ratio will remain unchanged. But if there's a vasospasm present, the velocity in the middle cerebral artery will be dramatically increased compared to the velocity in the internal carotid artery. So if we get a hemispheric index of greater than 3, that signifies pathology. So intracranial stenosis and occlusion. So we know with any stenosis, we're going to see increased flow velocities through that stenosis. We're going to see disturbed flow. So that's going to lead to our spectral broadening. So that's our turbulent flow that we get. There could also potentially be co-vibration phenomena. Sometimes conditions are hard to distinguish from stenosis. So some of those conditions can potentially be an intracranial arteries providing collateral flow, intracranial arteries supplying an arterial venous malformation, and vasospasm. So essentially, it's difficult for us to really determine the difference between a stenosis or a blockage in the artery versus just a vasospasm. Well, we know that vasospasms are a result of intracranial hemorrhage. So a major sequela or issue of patients that have intracranial hemorrhage is a vasospasm. So again, a vasospasm is a temporary, almost think of it like a kind of like a muscle spasm on the vessel. So the vessel spazzes and constricts, and that constriction causes essentially a stenosis or a narrowing of that vessel, leading to increased velocities and turbulent flow. So we also can have occlusion. And occlusion is defined as absence of arterial signal and an expected depth range, and presence of signals in vessels that communicate with the occluded artery. So we can diagnose occlusion when we have our flow through our communicating arteries or our collateral flow. And we can also diagnose occlusion via altered flow directions through communicating vessels, indicating collateralization. So this is our chart. So this is one of the charts that we use in the transcranial lab when we're doing our TCDs for our degree of stenosis. So for our middle cerebral arteries, velocity over 100 centimeters per second will equate to a greater than 50% stenosis. Over 128 centimeters per second will be a greater than 70% stenosis. For our ICA siphon, it's going to be 90. And then for our basilar and vertebral arteries, it's going to be 80, greater than 80 for our 50% stenosis. So it's easy to remember the greater than 50% stenosis. You got 100 for the MCA. Those are our fastest velocities. The next fastest is the ICA at 90, follow the basilar and vertebral arteries for our posterior circulation at 80. And then for greater than 70, it's just 128 and 119. So this is just a picture showing our normal flow in the middle cerebral artery. A nice healthy waveform with a nice spectral window. And number 2 shows increased systolic and diastolic peak velocities, spectral broadening, which is indicative of a turbulent flow. And then we also see turbulent flow distal to the stenosis. So we continue with spectral broadening. And we're starting to see the beginning of a tardus parvis waveform. So if we have a middle cerebral artery velocity of 171, that's going to be a greater than 70% stenosis. So here we have sampling 2 different areas of the middle cerebral artery. So in segment 1, we get a velocity of 66 centimeters per second. And segment 2, we get a velocity of 182 centimeters per second. So if we use a systolic ratio, we get a ratio of 2.8. So this indicates a stenosis of greater than 50%. So percent stenosis represents the measurement of diameter reduction. They can also, another exam that's potentially used is digital subtraction angiography. With our exams, we also are calculating mean flow velocities and stenotic to pre-stenotic ratios. So proximal to a stenosis or occlusion, there's increase in intracranial pressure. So that's when we were doing our carotid exams, we remember that a pre-stenotic waveform is going to be high resistance because that pressure is increasing. That clot or that blockage is increasing the pressure within the vessel. So that's why we result in a higher resistant waveform. So the image to the right showed a basal artery proximal to stenosis. So this looks more like a high resistant waveform. This looks more like maybe like an ECA type waveform, not what you'd see for a normal vessel that's bringing blood flow to the brain. So some pitfalls for transcranial Doppler could be lack of flow signal due to inadequate acoustic window. There could be misinterpretation of hemodynamic collateral channels or atriovenous malformation feeders at stenosis. Displacement of arteries because of space occupying lesions. So if the patient has some sort of brain mass or a large hemorrhage within the brain, if they've had a hemorrhagic stroke that's now causing shift within the brain, it will also, impact the vessels and shift the location of the vessels. Misinterpretation of physiologic variables in the circle of Willis. Misdiagnosis of vasospasm at a stenosis, or misdiagnosis of vasospasm as a stenosis. Misrepresentation of hyperemia following spontaneous recanalization of a stenosis. So what that means is if there is potentially a blockage or if there is a little piece of plaque that's occluding the vessel and all of a sudden that vessel becomes recanalized and reopens up, there's going to be a sudden rush of blood to fill the brain. And that that state of hyperemia or increased blood flow may result in misrepresentation of a stenosis. So difficulties with vertebral artery and basilar artery diagnosis. The normal flow and size of vessels are highly variable. So as you saw when we were imaging our vertebral arteries here in the lab, some of us had nice big vertebral arteries and some of us and really small, teeny tiny ones. The location and course of the arteries are unpredictable. And often the junction of the vertebral arteries cannot be reliably identified. So if we're using a non-imaging transcranial Doppler, we're just going based off our waveforms and the depth. But do we really know exactly where those two arteries have come together and pinpoint the exact junction of those arteries? It's difficult. We can't really tell for certainty, 100% certainty. The absence of vertebral flow signal on one side may not represent disease. So just because we're not getting a vertebral artery flow signal on one side doesn't necessarily mean that that vessel is occluded at that level. Perhaps there's a Steele syndrome going on. Occlusion of one vertebral artery or a top of basal artery occlusion does not necessarily lead to relevant flow abnormalities. So transcranial color-coded duplex sonography. So this is a diagnostic method allowing non-invasive imaging of intracranial vascular structures. Combines beam mode imaging with frequency-based color coding and Doppler sonography. So this provides more rapid and reliable vessel identification, reveals vascular and parenchymal anatomy, detects a wide variety of cerebral vascular pathologies, and monitoring intracranial artery stenosis. And you can confirm arterial occlusion diagnosis with this now. So transtemporal and transoccipital approaches are used usually. For transtemporal insonation, we look for a hypoechoic butterfly-shaped midbrain. Is visualized as an anatomic landmark at a depth of about 60 to 80 millimeters. For suboccipital insonation, a hypoechoic foramen magnum and a hyperechoic clivus serve as anatomic landmarks. So here we go. If the hypoechoic butterfly-shaped arrows at the midbrain, the hypoechoic xiphoid bone asterisk. So we can see on the color-coded picture, the posterior cerebral artery can be visualized as they follow the edge of the midbrain. Here. Your middle cerebral artery, anterior cerebral artery. This is a better picture showing that hypoechoic butterfly. Again, it's another picture of our transtemporal approach. Here's going to be your hypoechoic butterfly, your posterior communicating artery, posterior cerebral artery, middle cerebral artery, and anterior cerebral artery. Notice that not all the circle of Willis vessels are visualized here. So the vertebral arteries and the basal artery, the flow is away from the transducer. We're using the the suboccipital approach. So if we have our probe here, we have our vertebral arteries coming in and forming our basilar artery. So blood flow is going to be away from the transducer, coming down. Again, cameras here on the back of the head. We're imaging through the foramen. We see our vertebral arteries come together, forming the basilar artery. This is going to be your hyperechoic foramen magnum. You can use that as your landmark. And then the origin of the basal artery at a depth of about 75 to 95 millimeters in most cases. So detection of intracranial stenoses of 50% or greater reduction based on the table on the next slide show excellent accuracy. Occlusion diagnosis is based on absence of flow signal using both color and spectral Doppler modes. So with our color-coded exam, we're able to have 100% sensitivity and specificity when we have peak systolic velocities over these criteria. So for our middle cerebral artery, if we have a peak systolic velocity over 220, we can be 100% certain that there's a 50% or greater stenosis within that vessel. So for posterior communicating artery, posterior cerebral artery, it's 145, basilar artery 140, vertebral artery 120. And this is showing a pre-stenotic middle cerebral artery flow. And then at the stenosis, we get velocities of 300 centimeters per second. So this is a slide showing a patient. They were initially imaged and the proximal middle cerebral artery was occluded with contrast enhanced TCCS. The patient was given Levoquis in an acute stroke patient. And then we had recanalization, which occurred for the middle cerebral artery. So in a stroke patient with anterior circulatory symptoms, asymptomatic basilar artery stenosis, and a subclavian steal syndrome. So sickle cell anemia. We know this is an inherited disease caused by a defect in the gene that codes for hemoglobin. Erythrocyte appeared sickle and shaped and are fragile. It can adhere to blood vessels producing a blockage. So patients with sickle cell will often have painful, swollen extremities, decreased immune function, gallstones, and kidney failure, but they're also more prone to developing strokes. So this is an 8-year-old patient with sickle cell disease, and we were able to calculate a mean velocity of greater than 200 centimeters per second, and a corresponding MRA showed intracranial arterial narrowing within that segment. So arterial venous malformation and fistula. Arteries which exclusively or partially feed an arterial venous malformation can be identified with increased velocity, reduced pulsatility, and reduced responsiveness to CO2. These allow localization of AVM and its hemodynamic state. Draining veins can be identified by pulsatile flow and complete lack of flow response to Valsalva. AVF is detected by very high flow velocities and severe flow disturbances at the site, or by arterialized flow in veins that drain the fistula. So an arterial venous malformation is improper connection between the arterial and venous systems. So we can have an arterial venous malformation in other parts of the body as well as just the brain. So I touched on this a little bit, like for DMS, you may actually encounter an AVM when you're doing GYN exams on women that have had C-sections. Sometimes they can accidentally create an AVM or an arterial venous malformation as a result of the C-section, whereby you now have arterial blood entering the venous system. So these are almost like, consider them like fistulas. So monitoring of cerebral vasospasm. So there's intraoperative monitoring and intensive care unit monitoring. So vasospasm is a common complication which may occur between 4 and 14 days following a subarachnoid hemorrhage. The subarachnoid space is the area between the brain and the skull. It is normally filled with cerebral spinal fluid, which acts as a floating cushion to protect the brain. When blood is released into the subarachnoid space, it increases the pressure on the brain, making the person confused and lethargic, often caused by an aneurysm or AVM or trauma. Allow non-invasive monitoring to study blood flow velocities in basal arteries, providing valuable information in patients with subarachnoid hemorrhage before and after surgery. So this is called the triple H therapy. So hypertensive, hypervolumic, and hemodilution. So transcranial Doppler can detect increase in velocity before the onset of symptoms, hours to days before. It can allow an early diagnosis of cerebral vasospasm, early detection of those patients that are at risk to develop cerebral ischemia, as well as monitoring the benefits of available therapy. So this will allow for prophylactic treatment. So TCCS may directly visualize the aneurysm. So diagnosis of vasospasm is most accurate in the middle cerebral artery. Normal middle cerebral velocities are less than 120 centimeters per second, with a hemispheric ratio less than 3. And balloon angioplasty is the most common endovascular therapy in treatment of cerebral vasospasm. So this chart just shows the middle cerebral artery, anterior cerebral artery, and posterior cerebral artery waveforms. So we have on the right and on the left. And we see that the right side has much higher velocities than the left. So demonstrating increased velocities, suggesting vasospasm in this 42-year-old patient. The corresponding arteriogram demonstrates vasospasm of the right middle cerebral and anterior cerebral arteries. So over here we're getting 358 over 156, and over here we have 160 over 72, and 242 over 124, and over here 160 over 70. So this is just a chart that shows the clinical relevance of increased middle cerebral artery velocities after a subarachnoid hemorrhage. So if we have a time average peak or a mean velocity greater than 80, they should be observed further. If we exhibit mean velocities greater than 80 to 120, moderate vasospasm, preventative therapy is indicated. Critically accelerated would be 120 to 140, which would indicate a severe vasospasm, consequent treatment necessary, and higher than 140 for a mean velocity would be severe vasospasm. So here's the chart that they use for criteria at Christiana Hospital. So again, our middle cerebral artery velocities, normal would be less than 85, mild 85 to 120, moderate 120 to 150, severe 151 to 200, and critical over 200. And then your ratios, less than 3, 3 to 5.9, and then severe and critical greater than 6. So intraoperative monitoring using transcranial Doppler. So this is a non-invasive and allows continuous or intermittent monitoring, can detect rapid changes of blood supply, and deliver direct immediate information regarding cerebral perfusion, allowing rapid modification of therapy. Has been used in carotid endarterectomy, open heart surgery, and intensive care therapy. Intensive care unit monitoring using transcranial Doppler. So continuous monitoring by fixing probe at a certain location using a helmet-like device. Monitoring can be used for subarachnoid hemorrhage vasospasm, increased intracranial pressure after a head injury, cerebral vascular occlusive diseases, high or low pressure hydrocephalus, low flow states associated with extracranial and occlusive diseases, myocardial failure or valvular disease, or impending brain death. So with these patients in the ICUs, they may attach this device here, this helmet-like device, which will continually monitor the velocities. So aneurysm with coil treatment. So post-coil day 4. The right middle cerebral artery was 130, left middle cerebral artery was 136, but the basal artery was 219. So performing angioplasty to dilate arteries in critical spasm was necessary, increasing blood flow and preventing a cerebrovascular accident. So post angioplasty of the basal artery demonstrated now a flow velocity of 69 centimeters per second. So that was post angioplasty. So another use for transcranial Doppler is the detection of microembolic signals. So transcranial Doppler also allows one to non-invasively detect and quantify microemboli circulating through the cerebral arteries. A microembolic TCD signal must have random occurrence during the cardiac cycle. It's short in duration, less than 300 milliseconds. High intensity, at least 3 decibels above the background signal. It's mainly unidirectional within the Doppler spectrum. And there's an audible component, produce a characteristic sound like a chirp, snap, or moan. Permanent assessment of the acute thromboembolic risk, and permanent monitoring of treatment efficiency. So this shows the microembolic signals that you may pick up. These are just some more criteria for counting the embolic signals. It's transient, lasting 0.3 seconds. Embolic signature is visible at least 3 decibels higher than the highest spontaneous PMD display on the background. Unidirectional. The embolic signature must traverse a specific depth to determine the highest intensity of the insinuated artery. So power M mode Doppler shows track of emboli in time and space and provides simultaneous real-time assessment of emboli passing through different vessels, thereby increasing the yield of emboli detection with a single transducer. So this is just an example of the tracing using our color M mode or power M mode. And the bright lines show the microemboli. Another spectral tracing, you see the microemboli represented by the white lines. So a patent foraminal valley, or a PFO. So this is a right to left shunt in the heart. Can also be evaluated using transcranial Doppler. So this is a hole that's in the interatrial septum in the heart. So that septum separates the right and left atria. And blood flow typically does not get shunted across that interatrial septum, but when there's a PFO, that opening, blood flow from the right atrium gets shunted over into the left atrium of the heart. And this can be evaluated using transcranial Doppler. Patients wear special headgear to allow bilateral middle cerebral artery monitoring. A contrast agent like agitated saline is injected into the arm in the vein during resting state to detect any microemboli. Patient is asked to do a Valsalva maneuver. The microbubbles traveling through the PFO to the cerebral circulation display as high intensity transient signals or microemboli signals. Pfo grading criteria are based on the number of hits recorded following the injection of contrast. So with this agitated saline, if there is not a PFO present, those microbubbles will just end up in the lungs. So they'll dissipate in the lungs. They won't end up in the arterial circulation of the left side of the heart. Thus, they will not get to the brain. So that's how they're able to determine, if there is a PFO using this exam by detecting the presence of microemboli from that agitated saline, those saline bubbles in the vasculature of the brain. So the international consensus scale determined that even one hit is consistent with a PFO. This shows an example of a positive bubble study test for PFO. A patient with a large functional foraminal valley. And the Valsalva maneuver induced curtain of embolic signals in the middle cerebral artery indicating the presence of a large PFO. So we have the patient's Valsalva. The blood gets shunted, and we should be able to detect those microbubbles from the agitated saline. This shows a grading of a shunt. So cerebral venous thrombosis can also be diagnosed using our TCCS. Sonographic criteria are abnormal elevation of blood flow velocities within the intracranial sinus and veins. Direct visualization of cerebral sinus with decreased or absent flow. We can also determine brain death using transcranial Doppler. So brain death is based on critical criteria, which include electroencephalographic criteria, angiographic demonstration of absent intracranial circulation, must also demonstrate cerebral circulatory arrest, which was example of that shows reflux phenomena during late systole, as well as increased resistive indices, and must be in conjunction with other clinical and other laboratory markers of brain death. So this is just showing a Doppler tracing of what brain death progression would potentially look like. So our normal flow volume, has a large diastolic component, a nice low resistant arterial waveform. As it progresses, the waveform becomes higher and higher resistance until we eventually lose our diastolic component and we just have systolic peaks. And then eventually we see, this is another example showing we now have biphasic waveform, flow reversal, and then just systolic spikes, and then nothing at all. MCA in our common carotid artery and brain death. Middle cerebral artery, we should have a nice low resistant waveform, but in this, we have a very high resistant with flow reversal. Our common carotid artery, again, no diastolic component. This is the characteristic reflux phenomenon during late systole. The left image, ICA oscillating or reverberatory flow, is the hallmark of cerebral circulatory arrest. So the reverberatory flow is that flow that we get now below that baseline here. So we have systole and then rebound below the baseline. So assessment of effects of extracranial occlusive disease. Identify collateral flow in patients with extracranial carotid disease. So carotid stenosis or occlusion. So before we do our transcranial Doppler, we want to also be able to assess our extracranial vessels. We want to know if there's disease in the ICA, if there's disease in the vertebral arteries. So that'll give us a better indication of what we could potentially encounter upstream, or if the waveforms that we're getting upstream are a result of disease that's happening downstream. So transcranial Doppler and our TCCS are used to identify collateral flow in patient with extracranial carotid disease. The four main collateral pathways that can be distinguished are via the anterior communicating artery, the posterior communicating artery, the ophthalmic artery, due to those ECA, ICA branch connections, as well as via the ipsilateral leptomeningeal arteries. So sonographic criteria for intracranial collateralization. So we're going to see in our anterior communicating artery, retrograde and increased flow in the ACA on the same side, on the ipsilateral, towards the ipsilateral side. So if we have occlusion in the right ICA, the right, we're going to see retrograde flow and increased flow in the anterior cerebral artery on the same side. Orthograde and increased flow in the anterior cerebral artery on the contralateral side. Strong turbulence in the regions of the anterior communicating artery. So with the posterior communicating artery, we'll have direct visualization of the posterior communicating artery with our TCCS. We'll see increased velocities in the P1 segment of the posterior cerebral artery on the same side. Velocity ratio between the P1 and P2 segments of the PCA on the same side is going to be greater than 1.5. Increased velocities within the basilar artery and sometimes the vertebral arteries as well. Within the ophthalmic artery, we'll see retrograde flow or reversal of flow in the ipsilateral ophthalmic artery. And additional findings in extracranial ultrasonography would be a reduced pulsatility index within the ipsilateral external carotid artery. So basically what that means is we're going to have increased resistive indices. So a pulsatility index is essentially opposite of resistive indice. So contralateral velocity increases. So this is a patient with a left ICA occlusion. So left ICA is occluded. Blood flow is not getting to that left side of the brain through the ICA. So it's not getting into the left middle cerebral artery. So we have lower velocities in that left middle cerebral artery due to that occlusion. So we'll have, as a compensatory mechanism, increased velocities in the right middle cerebral artery. So assessment of effects of extracranial occlusive disease in the vertebro-basilar system. Subclavian, we'll see subclavian steel mechanisms. There could be rapid flow changes caused by vertebral artery restriction, and which can be measured within the basilar artery. So if the contralateral feeding vertebral artery is also diseased, the basilar artery flow may become reduced or might demonstrate a to and flow pattern or may be reversed. So latent steel, so subclavian steel mechanism. So in this picture, flow in the contralateral vertebral artery is increased during brachial hyperemia and is normal in the basilar artery. Manifest steel flow in the stealing vertebral artery is continually reversed. Basilar artery either has no effect, alternating or reversal of flow. So just because we have a steal in one side of the vertebral arteries, it may not affect flow in that basilar artery. So we may still have forward flow, or we may have alternating flow bidirectional, or we could have potentially reversal of flow. So these are just some more limitations of transcranial Doppler. And some of these we already went over. So operator experience, improper measurement control settings, poor windows. Patient had recent eye surgery. You can't go transorbital. Patient unwillingness to cooperate. Displacement of the arteries by an intracranial mass or lesion. Misidentification of vessels, and misinterpretation of collateral channels or vasospasm as a stenosis. Functional reserve testing. So transcranial Doppler is an ideal functional test for detecting rapid changes in cerebral perfusion. With changing CO2 concentrations, the relationship between the velocity and volume within a large cerebral artery is linear. Intactness of vasomotor reserve implies that a drop in perfusion pressure can be counterbalanced by vasodilation of cortical arterioles to maintain sufficient cortical blood supply. So vasomotor reserve may become exhausted if the resistant vessel of the brain areas with low perfusion pressure are already maximally dilated. So the doctors are going to try and dilate these vessels, and CO2 will help to dilate those vessels. And there's a direct correlation, between flow volume and the vessel diameter. Evaluate reserve mechanisms of cerebral vasculature by detecting rapid changes in cerebral perfusion under various stimuli, such as hypocapnia, hypercapnia, increase or decrease systemic arterial pressure, and hypoxia. A patient is in a supine position resting comfortably. A mask is put on to administer various concentrations of CO2. So CO2 has a dilatory effect and is mainly restricted to peripheral arterial vascular beds, such as the small cortical vessels. So transcranial Doppler of changes related to CO2 administration. So basically they're doing this to assess how much increase in blood flow can we get, how much can we make those veins dilate and how much the brain is able to compensate. So flow volume and flow volume of large cerebral arteries show a linear relationship in changing CO2 concentrations. So ultrasound perfusion imaging, using ultrasound contrast agent to enhance B mode imaging and allow ultrasound-based measurements of tissue perfusion. Introduction of contrast agent via bolus tracking approach or refill kinetics. So this is a 70-year-old patient with a MCA infarct. Ultrasound perfusion studies were done following a 2.5 millimeter Sonoview bolus injection of contrast agent. And B showed 2.5 hours after onset of symptoms. And this was a CT 180 hours after the onset of symptoms. This is a newer adaptation for ultrasound now with the advent of 3D probes. We're able to do 3D TCCS exams. So this is a new non-invasive method to investigate intracranial aneurysm. The data can be post-processed by different investigators and yields an excellent correlation with gold standard. May be possible to improve reproducibility and increase objectivity of transcranial color-coded duplex sonography. So we could do power-based 3D, TCCS, and ultrasound with contrast agents. So Ultrasound can also be assisted, can be used in the assistance of thrombolysis. So ultrasound assisted thrombolysis or sonothrombolysis is the insonation of thrombus alone or in combination with fibrinolytic agents to accelerate the thrombolytic process. So using frequencies between 20 kilohertz and 3 megahertz and intensities between 3 milliwatts and 8 milliwatts per meter squared. So microstructural alterations are mainly responsible for sonothrombolytic effect via microcavitation process. So if we go back to our physics, our cavitation, when we put energy into any tissue, the cells begin to oscillate or vibrate, and that's that cavitation. So we can actually use that cavitation to break up clot. May increase the efficacy of pure pharmacological approach of thrombolysis in acute stroke and improve long-term outcome of stroke patients. Use of echo contrast enhanced agents can enhance the effect further through microbubble induced cavitation. So some of those micro agents that we use, like the agitated saline, will help to add to that cavitational effect that the ultrasound beam is having on the blood or the thrombus and help to break up that plaque or thrombus further. This is actually a new procedure that I've actually done in the vascular lab with peripheral arterial exams. This use of microbubble exams, these microbubble studies where we injected the microbubble agitated saline into the vessels, and we have the contrast flow down the leg to the occluded arteries in the leg, these small arteries, and using the ultrasound machine helped to break open some of that plaque and open up the small vessels of the leg to increase perfusion to the leg. So I've actually done that in the peripheral vascular lab. So establishing sonographic thrombolysis as a therapeutic tool could revolutionize the treatment of acute stroke. Risk for intracerebral hemorrhage is currently under investigation. So acute thromboembolism of the MCA. So you can see the absent waveform versus a blunted or dampened waveform versus what a stenotic waveform would look like. We have your increased velocities versus a normal waveform. So we know that high resistant flow signals are seen proximal to any stenosis or blockage. And post stenosis, we have a return to diastolic flow, but it's usually lower resistant, not lower resistant, lower velocity. Apologize. So I promise you all this transcranial stuff is going to make a whole lot more sense when you go in the fall to the TCD lab with Mary Jo, and you're actually scanning it and being able to see the vessels like, oh, all right, there's the middle cerebral artery. There's the, anterior cerebral artery when you go through your windows. And you're not going to be expected, to memorize all the velocities. There'll be a chart in every lab that you work in. The main takeaway from Transcranial Doppler is the main indication we do it to evaluate for stroke and for the presence of vasospasm. So patients that have had strokes and patients that are susceptible to developing vasospasm. So anyone who's had any sort of subarachnoid hemorrhage, any sort of brain bleed, any sort of trauma to the head, post-surgical patients for post-cranial surgery. They're susceptible to developing vasospasm. I think anything I really need to touch on. That's about it. Anyway, so again, when you guys come in for the lab, I'm going to be giving you guys your Scantrons, and I'll print out that last report answer sheet for the quiz. The quiz is posted on D2L, so you guys can do it at your leisure when you have time. Just make sure they're submitted, the day before the class, so we can I can have them graded and we can all review them. And we're going to do some carotid artery scanning when you guys come into the lab. I'm gonna have you guys all do the left side today. All right. I will see you guys later. Have a good lunch.
Thanks, Dan. Bye.
Bye.